So we'll talk about past, present, future of electronic records, infrastructure we need to provide the electronic platform for acute kidney injury detection, making of acute kidney injury sniffer in action, and testing of acute kidney injury in a novel application, and then what are the next steps. It is wrong to think that electronic clinical informatics are better than human beings. Clinicians are generally better than computers alone. So what is Friedman fundamental theorem mentions is that if you add electronic records to human beings with a scientific database and methodologies, it would be better than clinicians alone. As of 1953, that first monitor, cerebral artery monitor, was implemented in ICU. There's been significant growth of electronic records or electronic monitoring systems in ICU setting. Until 1967, that first ICU monitor was implemented in Japan, and the size of these monitors were larger than patients' beds, so they had to sit in a different room with a couple of human monitors to be able to interpret the data generated by them. Development of microprocessors has allowed clinical records and electronic health records to grow from first generation that only collected data to third generation that is allowing gather significant amount of data for us. CMS encouraged meaningful use of electronic records, which includes three different steps: data capture and sharing, advanced clinical processes, and showing patient improvement in outcome. And that has resulted in significant increase in the use of electronic health records in the United States. This is a little older data until 2010. However, it shows that about 20% of physicians using electronic health records increased to 50%. Almost half of these clinical providers are using very basic modes of electronic health records, and only about 10% were using very highly sophisticated records. And in 2009 was the time that we joined the functional systems. So we moved from handwritten records, it was very hard to read, very hard to interpret, to EMR that was very legible, however, still very difficult to interpret based on data, to ambient intelligence to be able to provide data to us in a fashion that we need to make a decision. So this was, unlike the electronic health record, this was designed by physicians along with information technologists. The previous records was designed or adapted from accounting databases that was not very appropriate for our clinical use. So for electronic acute kidney injury sniffer, we need several structures to be built before we can use electronic health record to detect acute kidney injury. First, we need some databases that are accessible. And then we need electronic surveillance syndrome recognition tool, which has two distinct components. One would be repository of data, which needs to abstract data from all these different databases and link them together. This is the problem with third generation of medical records that we have, and it's very fragmented. There are a lot of information that are not linked together and not usable easily. And then this repository needs to have a rule engine to be able to define algorithms to identify clinical syndromes. And then obviously we need notification component, which could be in a form of email, pager, overhead notification, EMR, or mobile tools. So around early 2000s, we started collecting data from all different databases available for every patient, from outpatient and inpatient records. The minute the patients arrived in ICU, we started collecting that data in a near real-time basis with 15-minute delay in vital signs, but everything else was real-time, adopted into a repository, we called it ICU Data Mart. ICU Data Mart had all this information linked together, so avoided the fragmentation issues of the generation of medical records. After collecting information in ICU data mart, we defined algorithms to define clinical syndromes, acute lung injury, sepsis, acute kidney injury, and that allowed us to have an alert database that is connected to a router that can generate notification. In AKI 15, we looked into studies that looking into acute kidney injury e-alerting. There are several presentations and studies looking into large number of patients that provide information about acute kidney injury sniffers. And this last study is a study that we did in Mayo Clinic. I'll describe it in the next few slides. There are studies with acute kidney injury e-alerts that shows positive results in processes of care or outcome. Some of them are only process of care, decreasing nephrotoxic exposures or increasing contrast prophylaxis. Some of them show improvement in patient outcome, including decreased acute kidney injury or even decreased mortality. There are few studies that didn't show any benefit. And to describe why I think that these are different results from different studies, I would like to kind of present a case study in the next slide. Before we do that, I would like to talk about the processes of acute kidney injury e-alerting. When an alert is generated, the expectation is to improve processes of care, and that improves clinical outcome. And that depends on the provider and provider behavior, and therefore it depends on provider acceptance. And that is impacted by a significant number of factors. If electronic health record is available, if it is accurate, if you receive a large number of inaccurate data from electronic health records, it just makes you ignore them in a few days. Clinical relevance is important. If you receive electronic alert regarding to the need for screening colonoscopy for ICU patient, it would be irrelevant. Rather, receiving information of impending acute kidney injury. If the database is basic versus advanced, so it can give you intelligent alerting versus some very basic alerting. Human factors are important. We need to prioritize the alerts. As Dr. Bagshaw mentioned, some institutions develop significant information overload by providing significant number of alerts. So we have to prioritize things that are more important and impact patients' outcomes significantly more. We need to identify what we actually want to, what the message is that we want to pass. If this is just the urgency of the matter along with the nature of the problem, or we want to include some solutions and maybe some outcomes of not following the solutions. We tend to habituate to alerts. After a little while, we stop thinking about alerts. We don't pay attention to alerts. One way to avoid that is to provide constant feedback about performance of the clinicians following alert systems. Targets are important: physician, trainees, or allied health staff. Who receives these alerts? And context, if it is clinical or administrative. Finally, delivery methods are very important in provider behavior. For example, hierarchy of delivery of alerts. If you just push this alert as a pager without any follow-up, or you make a stop station so clinicians cannot move forward without implementing those changes. Timing, if you want to batch these alerts or you want to have a real-time alert. If you want the clinicians to acknowledge, receive their alerts, if you want to place it in a way that physicians can easily look at it, or they need to move to a different room to find it, or using different fonts and different colors to attract attention of the physicians and providers. Now, the case study I promised. This is a study by Colpert. It's a before and after implementation of electronic alerts. So the intervention group, 616 patients received 1,400 alerts. You can immediately say that these are lots of alerts for this number of patients. However, they were able to show significant improvement in processes of outcome and rapid correction of serum creatinine within 8 hours in the alert group in comparison with pre and post control groups. The other study is Perry Wilson's study, is a very well-designed randomized controlled trial of 2,400 patients which were assigned to alert group and control group. Control group, the patient received usual care, and alert group, pager went to intern or resident on the floor, and then there was no follow-up. So they had to kind of implement what they felt that is correct. So to compare these two studies with different results, the design of the studies obviously are different. In Colpert study, urine output and serum creatinine was used and rifle criteria. In Perry-Wilson study, KDIGO serum creatinine criterion was used. In Colpert study, anytime that patient moved to a different stage of acute kidney injury, providers receive an alert, while in Perry-Wilson study, there was just one alert generated. Alert in Colpert study went to intensivists. For Perry-Wilson went to interns, residents, or MPPAs. It was in ICU for Belgian study, and it was in medical surgical ICUs and wards for Perry-Wilson study. And then outcome, primary outcome for Colpert study was processes of care rather than clinical outcome. And it was clinical outcome for Perry-Wilson study, which is very hard target to hit by one single intervention, if you will. Care bundles and electronic alerts work, and this is a great example of such model. Coley and group, Nick Selby group, they describe how they implemented electronic alerting system in their hospital. So in June 2010, they were able to recognize acute kidney injury using electronic health records. In March 2011, they were able to generate report of acute kidney injury. In August 2012, they came up with this paper form of care bundle. And in February 2013, they were able to provide electronic AKI alert and care bundle to the physicians. And a few months later, they started having interruption on the patient's workload to be able to make sure they follow care bundle. So this is a care bundle in a paper form, care bundle in electronic form, and then they provided stop and checkpoint. So physicians could not go forward unless they were addressing the issues raised by care alerts. They showed that attachment to the care bundle within the first 24 hours increased from 2% from no interruption to 22% in interruption group. And those who actually followed the care bundle within the first 24 hours showed their patient at discharge 30 days and 60 days had significantly lower mortality. So one single intervention was able to decrease mortality significantly. Now, how did we come up with our own acute kidney injury sniffer? We used the consensus definition of acute kidney injury network criteria at the time of the study. We had the training and test cohorts. In each cohort, all patients, which was 482 and 462 patients, was reviewed by 2 independent reviewers to identify AKI. And there was an excellent agreement between them with kappa of 0.94 in each cohort. And the disagreements were dissolved by an expert nephrologist. And we used lots of reiteration of acute kidney injury sniffer in a training cohort and then tested in a validation cohort. We encountered several problems, as it is obvious in other studies as well. We only had 60% of patients had baseline serum creatinine, which we defined as median serum creatinine within 180 days prior to admission. For those who didn't have baseline serum creatinine, as is recommended in literature, we use MDRD formula. However, we found that if we, instead of 75 ml per minute per body surface area, baseline estimated GFR, if we use 60 ml per minute per body surface area, we do not lose a lot of sensitivity, we gain significant amount of specificity. So we use that in training cohort and then validated it in validation cohort. We also came up with mathematical model to be able to distribute recorded urine output to allow us to follow urine output in a trend and almost hourly basis urine output. So what we found in training cohort, that sensitivity of the tool was 88%, specificity 95%, and the performance was similar in the training cohort. When we looked into ICD-9 codes in comparison with gold standard reviewer reviews, we noticed a very good specificity as this is recommended in literature, but sensitivity was very low of about 20% in testing cohort, which means 80% of patients did not have any documentation of acute kidney injury or billable documentation of acute kidney injury in their chart. So this is how our monitors look like. These are all patient beds. Each patient is assigned numbers from 0 to 3. Each number indicates the stage of acute kidney injury. So if I click stage 3, it opens when the trend of acute kidney injuries, so when patients reach stage 2 and stage 3. And also tells us based on what criterion they achieved acute kidney injury stage, and also more information regarding to baseline serum creatinine, current serum creatinine, and average urine output. Now, we use this sniffer in a novel research application. We wanted to evaluate the temporal trend of acute kidney injury on an annual basis in a population-based study. So all of you are familiar with this next couple of slides that describes acute kidney injury in hospitalized patients. The first study looked into late part of 1990s, early 2000s, acute kidney injury in a community base among hospitalized patients and showed increase in the incidence of acute kidney injury. And also they looked into acute kidney injury that required dialysis and again showed increase in the number of dialysis in this patient population. Follow-up study by Ray Su showed increasing number of patients who need dialysis following acute kidney injury, and that was among hospitalized patients using very large national databases of hospitalized patients. So there are issues with using these kind of studies, epidemiology studies, and particularly looking at temporal trend of acute kidney injury. First of all, although administrative data have a very significant specificity, they have a very low sensitivity. Although it has improved from 1994 from 17% to 29%, improved about 12%, still cannot explain increase in the number of acute kidney injuries. One may argue that incentivized documentation can explain this increased number of acute kidney injury reporting. However, that should have been more abrupt increase when policies are made rather than a steady increase that we see in literature. Those studies that look into temporal trend of acute kidney injury using biomarker definition of acute kidney injury have to deal with significant number of patients who do not have baseline serum creatinine, and they use imputation of estimated GFR of 75, which, as I mentioned, inflates the data. And as I mentioned, we use 60 ml per minute per body surface area to mitigate inflation. Some studies have used first hospital serum creatinine, which deflates incidence of acute kidney injury by ignoring patients who have community-acquired acute kidney injury. And a lot of studies do not use urine output in large-scale studies to evaluate the incidence of acute kidney injury. Dialysis dialysis administrative data is very accurate, however, sensitivity of 90%, specificity of 94%. So Ray Su's study was very accurate. And that increasing incidence could be explained by earlier, more liberal use of renal replacement therapy or increasing comorbidities and acute exposures that we all know about. Now, one of the major issues with these studies is that all of these studies use hospitalized patients as at-risk group when they calculate their incidence rate. There are very limited number of studies that have looked into a population of patients, individuals, rather than hospitalized patients. And we wanted to test our sniffer in a population-based study. So we used 3 different methodologies to adjudicate acute kidney injury in our study. We use acute kidney injury sniffer, which we use our validated sniffer, ICD-9 administrative codes, and dialysis requiring acute kidney injury based on administrative codes. When we use hospitalized patients the same way as literature currently indicates as at-risk group, we identified 10,000 patients in ICU, about 42,000 patients in the hospital ward, all residents of Olmsted County, and I describe Olmsted County in a minute. ICU patients obviously had significantly higher comorbidities and acute exposures. They also had increased incidence of acute kidney injury in comparison with the ward patients. Interestingly, ICD-9, they had similar incidence in ICU in a hospital, and that shows lack of sensitivity in ICU and maybe poor specificity in the ward patients. When we use unadjusted analysis for hospitalized patients, we found increasing incidence of acute kidney injury in ICU and in the ward. Now, we repeated that analysis using the whole population of Olmsted County as our at-risk group. Olmsted County is an isolated county that Mayo Clinic is located at. And the closest other medical center to Olmsted County is about 150 kilometers far. Mayo Clinic is the only institution that provides intensive care, nephrology, and dialysis. So we, based on previous data, we know more than 99% of patients who require intensive care, they receive their care from Mayo Clinic. This county has about 150,000 population. That this is a population of adult patients and then male population in this county. We notice patients, individuals that are in 18 to 54-year-old range that are declining. However, patients that are above 55-year-old are increasing, so population is aging. When we use unadjusted analysis of incidence rate, we didn't find any increase in acute kidney injury among Olmsted County residents. And we found a slight increase in acute kidney injury incidence among hospitalized patients. This is unadjusted analysis. When we use acute kidney injury in ICU and ward, we notice increasing incidence of acute kidney injury. Obviously, acute kidney injury is stage 3 in the ward, and dialysis in the ward was driving for increasing incidence of acute kidney injury. In all ICU, ward, or all patients, we showed ICD-9 in unadjusted analysis shows increasing incidence of acute kidney injury, and this is probably due to improvement in documentation or incentivized documentation. When we used age and sex adjustment for acute kidney injury, all the trends disappeared. There is no increasing incidence of acute kidney injury among each age group or gender. This is based on ICD-9, which didn't show any increasing incidence, and also dialysis as well. So this is based on a sniffer. As you can see, none of the groups showed increasing incidence. If there is anything, there is slight trend toward decreasing incidence of acute kidney injury among the whole population of patients. Now, we are moving to the next steps. This is data that we reported the preliminary results in CRT meeting, and we have moved this a little more forward. We use random forest models to identify patients who have higher risk of acute kidney injury. This is different from detection. This is prediction of acute kidney injury. So this model can provide 0 to 100 score risk, acute kidney injury score risk, and this is output of one single patient. This patient, for example, started from score of 70, which is very high risk. Score increased because blood pressure decreased, heart rate increased, and 12 hours later, the sniffer that I described earlier identified patient as acute kidney injury. And following treatment, obviously, you can see the score rate continues to decline. In a derivation cohort, performance of this model was excellent at 0.95, and in validation cohort, it was 0.87, still very strong model. The issue is that we didn't gain that many hours, golden hours, by using this prediction model, mainly because, so this is CDF form that shows time of diagnosis of acute kidney injury in the red line. As you can see, majority of patients reach diagnosis of acute kidney injury very early in a hospital, in ICU setting. So the time that to be gained is not very significant. It was about 5 hours using prediction model. So this is a part that is, we cannot achieve any further prediction because these are patients who have acute kidney injury. We have achieved this much time by using prediction model, and we are trying to improve our models to be able to improve the time gained by using prediction models. In these models, as you notice, there are many acute exposure criteria, not many comorbidities. And we tried to force comorbidities inside the model and did not accept it. So because acute exposure are so important risk factors for acute kidney injury. So what we are doing, we are trying to use logistic models using comorbidities and try to have a model that output includes this model and different other models that we are working with, and that logistic model, hopefully we can improve the performance and the time gained for the model. Take-home points, electronic health record utilization is on the rise. Need for better data mining and processing is obvious. Acute kidney injury ELR shown to be beneficial in most circumstances. Design of EHR studies is important in observed outcomes. EHR application includes patient care and research, and I showed you an example of a large epidemiology study. It could be used in randomized clinical trial enrollment, as Dr. Bagshaw mentioned. And detection, prediction, clinical decision support systems are steps that EHR needs to take to improve its performance in process of care and patient outcome. With that, I thank you for your attention.